How's it going, guys? So very bread and butter question for 2CK surgery. I will discuss some mistakes that students make regarding a few of these answer choices here, just a couple simple points that will benefit you. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram, Mehlman_medical, MEHL, MAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now starting the actual question here, where we've got this 17-year-old boy, fell and hit his head. Physical exam shows he has stuporous, so he has a decreased Glasgow Coma scale. Vital signs are within normal limits. A non-contrast CT the head is shown. So we do non-contrast CT when we're looking for bleeds. Contrast would be for things like brain abscess, cancer. And you can see that he has this biconvex disc, which is our epidural hematoma. Okay, so obviously that's a step one discussion if we're going to talk about the different bleeds and which vessels are ruptured, etc. But the point is, this is an epidural hematoma. And we say, well, how are we going to manage this? So we look at the answer choices here, and right away, craniotomy, you want to be careful, okay? I've seen this as a correct answer, but I say you want to be careful because when we want to look at the other answer choices, and if you see intubation, hyperventilation listed, this is the correct answer, okay? When we talk about intracranial bleeds, you need to know that decreased CO2 causes decreased cerebral perfusion, especially in a patient who has a low GCS. It's not mandatory the patient has a low GCS, okay? But if they give you intubation hyperventilation as an answer in the setting of an intracranial bleed, you're going to choose it, okay? It's very important. So normal CO2, 33 to 44 millimeters of mercury. We want to achieve what's called permissive hypocapnia, where we lower the patient's CO2 no lower than 26 millimeters of mercury. If we go below 26, we can actually precipitate an ischemic stroke because we've reduced cerebral perfusion so much. So intubation hyperventilation. If they don't list this, okay, craniotomy is going to be the answer. I've seen this for subdural and epidural on 2CK material, okay? If intubation hyperventilation not listed. They can also say burr hole. It's the same thing, okay? You Google it, burr hole. It's just relieving pressure. They're not going to list burr hole and craniotomy at the same time. It's the same thing. Mannitol, all right? Now, mannitol serves a role in decreasing intracranial pressure. This can be listed. This can be the correct answer if they don't have craniotomy or intubation hyperventilation listed, okay? If they force you to choose a medication, let's say, in the setting of increased intracranial pressure, you can be aware that mannitol can be given, all right? But it's not a frequent answer. It's not. As I said, they like intubation hyperventilation, and if that's not listed, you're going to choose craniotomy. Now, steroids, wrong fucking answer in the setting of bleeds. That's very important. Steroids, however, are a very important answer for brain cancer, primary and metastatic, as well as mets to the spine, okay? If we have neurologic abnormalities. So patient has history of prostate cancer, breast cancer, and now has neurologic abnormalities, let's say in the legs, we're going to choose IV methylprednisolone, okay? So we assume that there's mets to the spine. Very important answer here. For spinal cord trauma as well, you want to do steroids, okay? Decrease inflammation, okay? Cancer in the CNS, steroids. Wrong fucking answer for bleeds. Lumbar puncture is going to be a correct answer for management of normal pressure hydrocephalus, okay? So if they show you a CT scan with enlarged ventricles due to this wet, wobbly, wacky, plus or minus Parkinsonism, normal pressure hydrocephalus can present with Parkinsonism. That's very fucking important for 2CK neuro. You can do a lumbar puncture removing 30 to 40 milliliters of CSF. That can be therapeutic, okay? So as I said, not going to make this an extended clip. Intubation hyperventilation, very fucking important answer for 2CK. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.